Hello, my name is Raj Gupta, and I'm here with Dr. Nigel Sharrock, who received the Gaston Labat Award in 2017. This interview is part of the activities surrounding the 100th anniversary of the founding of the American Society of Regional Anesthesia in 1923 by Gaston Labat and colleagues. Although this organization is not related to the current day ASRA pain medicine directly, which was founded in 1975, it has been said that the current society would not have existed quite like it does without the work of Dr. Labat and the original ASRA. So today we're talking about the memories and experiences of Dr. Nigel Sharrock. Dr. Sharrock, nice to meet you and welcome.
Good to meet you. Welcome. Thanks very much for doing this, Raj.
Well, your reputation precedes you, but we have actually never, I think, formally met in person. So it's good to chat with you about this. And I love hearing of your experiences through this organization and obviously in our field of regional anesthesia. So that leads me to my first question. What led you to choose regional anesthesia at the early part of your career?
Well, when I was a resident, I was very impressed by the publications of Phil Bromage and Henry Kellett, showing that the metabolic response to surgery was attenuated or blunted by the use of regional anesthesia compared with general anesthesia. So I thought that that was a better way to proceed with almost any anesthetic, if you could, was to use some form of regional anesthesia. And that's really what got me interested in the field.
And was regional anesthesia being used much at that time in your institution, or did you kind of have to institute it?
No, I think at that point, the only regional anesthesia that was used was spinal anesthesia. Some institutions other than ours were using auxiliary blocks as well, but regional anesthesia was not widely used at that point. Danny Moore had published his book on regional anesthesia, and some institutions were facile at the art of regional anesthesia, but not the institutions that I trained in.
Fair enough. And when you were coming up through the field and then also assuming a leadership role, I know you had quite a presence at the Hospital for Special Surgery in New York eventually, and mentored quite a few people in this field. What were the predominant issues in the field at that time? What did you feel like needed to be addressed?
Well, I think the predominant issue at the time was what was safer to do a regional anesthetic or a general anesthetic. And I spent a couple of years at the Peter Ben Brigham working with Leroy Van Dam, and he was a big proponent of spinal anesthesia, using anything to try and avoid a general anesthetic. He had a sort of philosophy which was very similar to mine. And I think the biggest issue was really what was a safer anesthetic to use.
And at the time, when you think about peripheral nerve blocks, what do you think the safety issues were, and how did you guys explore those?
Peripheral nerve blocks of the lower extremity were more talked about than practiced. I think it was really the paresthesia techniques were sort of somewhat unreliable, using sciatic and femoral blocks. So although you were sort of, you knew they existed, I mean, I never really practiced them. I thought they were very, very difficult to do. In the upper extremity, I taught myself how to do interscalene blocks and would use decent volumes of local anesthetic to achieve anesthesia for the hand and elbow with interscalene blocks. And I started doing those as a resident and continued at the Brigham, and when I was at Lenox Hill, and then again at HSS. And
your safety issues were toxicity, nerve damage? What kind of stuff were you running into?
Really didn't run into toxicity issues, and nerve damage didn't seem to be a problem. I conducted one informal survey where I followed up 100 patients and knew their sites of paresthesia. And only one patient had a mild paresthesia, which would coincide with the site of the paresthesia. Any other peripheral injuries were related to the sites of surgery. So I didn't feel that these blocks were particularly dangerous in terms of peripheral nerve damage, and I wasn't seeing any toxicity.
Now, you mentioned paresthesia technique, so this kind of leads me to my next question, is how has the field evolved over your career? And I'm sure there's lots of significant changes that have happened.
Yeah, well, it's I think the field of peripheral neural blockade has changed dramatically, as you well know. uh, relying on paresthesia and body landmarks required a knowledge of surface anatomy and being able to sort of manage patients and not over-sedate them. So you had to be confident in what you were doing and not mess around too much. And it was a bit of an art, and it was very difficult to train people to do these. So a lot of people may have started out trying to do them, but there was many didn't pursue it because it was not as easy to do as a general anesthetic. So paresthesia, relying on paresthesia and body landmarks really sort of, when it was the only way to do it, sort of held the field back to a significant extent. I think people realized the advantages of these blocks when they worked, but they were difficult to achieve, at least on a generalizable basis. The next real change in peripheral blockade was the introduction of nerve stimulation, which enabled one to sedate patients so that they would be unaware of the needles going in, and you could teach a lot easier. And the endpoints were pretty clear cut. Again, you needed a knowledge of surface anatomy, but that was all right. And I think that was a major advance, and the field took off really significantly with nerve stimulation. But it wasn't until the advent of ultrasound that the field really became one where anybody could learn it, and they could become proficient by watching videos and going to workshops, and made the introduction of peripheral blockade more generalizable in the general community. With neuraxial blocks, I think the biggest change that's occurred has really been the introduction of Whittaker needles. I think these have made the rate of clearly dural puncture headaches have dropped, and the manufacturing of these is really a pretty fine art. And I think that spinal anesthesia has become more widely used than epidural anesthesia.
Do you think that, go ahead, sorry.
No, I was going to say you could debate which is better. I think they wind up achieving sort of similar things, especially if you dose epidurals with more local anesthetic. And there's different issues in terms of managing the patient's hemodynamics. But, I think that the two techniques really are sort of interchangeable. But epidurals are harder to teach and probably harder to master and have a less clear endpoint. So I think in teaching programs and in just general practice, I think spinals have become more popular.
Do you think that these changes, these evolutions in the field that make them more accessible, both peripheral and neuraxial techniques, more accessible to more anesthesiologists, is good for the field or diminishes its quality and value?
No, I think it's very good for the field. I think that the whole idea is as a specialty, is to be able to provide more optimal anesthesia. I think anything we can do to do that is really excellent. The days of the people who were accomplished in the art of regional anesthesia may feel that it's become a little bit diminished, but I'm not a believer in that at all. I think getting techniques which are easy to teach, and so the techniques can become more generalizable, is very, very good for the field.
So during your career, and obviously you've had leadership roles at different places that you've been involved, what changes in thinking or practice or perspective do you feel like you fostered that were influential to your trainees and to people who went out into practice?
I think the big thing was to foster the use of a regional anesthetic wherever possible, and try and eliminate some of the sort of what I call armchair philosophical reasons not to use a regional anesthetic. Armchair philosophical reasons would be things like history of multiple sclerosis or prior stroke or something like that, which people would often use as an excuse not to use a regional anesthesia. So I have been a big believer in trying to foster, a more generalizable use of regional anesthesia, and secondly, to do it in an excellent way. So you're not only using a regional anesthesia, but I call it excellent regional anesthesia. The other thing I've promoted is the use of lowering blood pressure down during major surgeries to reduce blood loss, and that has a number of benefits. So the combination of an epidural with hypotension is an excellent anesthetic for joint replacements, which is really where I spent my career practicing. But I think it's a technique that can be applied elsewhere as well. Again, it needs to be taught properly and properly performed, but done optimally, it's extremely safe and very, very worthwhile.
How did you approach probably the number one issue where people are reluctant to use regional, both from the anesthesiologist side and the surgical side, is time. Time and efficiency.
Sure.
That's everybody's problem, right?
Yeah, exactly. Well, I think I tried to get people to become proficient at doing these blocks, so they didn't take too much time. And when I was first introducing regional anesthesia at the Hospital for Special Surgery, I made it a point to, I had a nurse anaesthetist working with me, and I was free, and we were able to, if someone was having trouble, I went in there and helped them get the block started quickly, promoting the concept of doing the blocks in a timely fashion, and then went around promoting the benefits of the blocks. And I think the use of regional anesthesia and joint replacements was so stark and dramatic that the surgeons were prepared to wait a few more minutes to get things started. The other thing that existed was we had a lot of patients with rheumatoid arthritis and difficult airways. So general anesthesia often took a long time to get going as well.
Who do you consider you mentioned a few names during this, people who've mentored you over the years or inspired you. Who do you feel like are your greatest mentors when you think back on your career?
I had really two sets of mentors. I did some research in medical school, and my mentor for that was a chap called Ted Nye, who was an authority in ischemic heart disease and exercise. And then I spent 3 months at Vanderbilt, again with another person involved with exercise physiology. And they were, MD, PhDs and full-time researchers, and they had a big impact on me in terms of, my ability to initiate a study and get it finished and make sure it was published. They were very good in that regard. My mentors in regional anesthesia, my main two mentors were Leroy Van Dam at the Brigham, who had been head of the Journal of Anesthesiology for about 10 years and was a senior professor in the Harvard system. And he was a big promoter of regional anesthesia and had a big influence on me. He taught me to write and, supported me in every way. I was doing a series of studies up there, and he would assign the cases in such a way that I could do them. He was a big believer in individual anesthesiologists practicing, and was a big believer in excellence and safety. And I learned a tremendous amount from him. He was a real taskmaster, and I think that rubbed off on me.
Usually the best mentors are, I think.
Yeah, I think so. That's right. And the final mentor was a chap called Bob Boas, who was a fellow New Zealander who worked at Worcester in Massachusetts when I was up there. And I used to go and see him on some of my days off. And he was a pain management guy and use of sympathetic blocks and other modalities. And I also met Michael Stanton Hicks, who was the chairman there at the time. So those were my real mentors. Much of what I did was read and learn regional anesthesia by looking at anatomy and talking to people. So I had a lot of people who gave me, input into a lot of the things that I did.
Yeah. So incidentally, I'm at Vanderbilt myself right now. I didn't realize that you had spent 3 months here. That's interesting. So I've been on faculty here for about 16 years, did my undergrad and med school at Vanderbilt. So I have a long career here.
Oh, this was back in 69, 70.
I won't tell you what year I was born, so then that might not be appropriate for this conversation. You mentioned the importance of different people that you've communicated with to help you learn. I think that part of what I've enjoyed about ASRA Pain Medicine Society has been that collaboration and that ability to access experts who have tried and experimented and managed to succeed through these challenges at their own institutions. When you think about the society, what words do you think of to define the society to you? What does it mean to you over your years?
Well, I think it's a society which promotes the use of regional anesthesia through research and education. I think is probably the best summary. It's been an excellent society. It's obviously changed dramatically.
Sure.
I remember going to the second meeting of the, I presented a paper there, and Alan Winnie was on this, was the moderator, and Danny Moore was sitting in the front row, and all those, Raj was there, these old people from the olden days who were real key people in regional anesthesia. So they had, by the second meeting, had assembled pretty much the who's who of regional anesthesia in the meeting. And it's continued that way. I mean, they've done a really wonderful job, and the society has expanded. It's in its terms of its scope, I think, but its mission, I think, remains the same, which is to promote, the field and promote excellence in the field. And you do that through research and education. And I think they do both very, very well. And the membership's got to be very proud of all the people who put all hard work in, like you do, to make it successful.
Do you remember how many people were at that meeting that you went to, that second?
Probably a couple of hundred.
Yeah, I think the meeting that I was in charge of, which was the last one before the pandemic started, we had about 1,850 people at the meeting.
Exactly.
So that's an impressive growth
over
that
exactly.
time. Yeah.
Yeah.
And I think that what you mentioned earlier about the advent of ultrasound, making it more accessible to people, has expanded the pool of people interested in the field.
Sure, which is good. Yeah.
So my last question for you is, what was your initial reaction to the news that you had received the Labat Award?
Well, I was surprised, but hugely honored. I mean, I think it's the ultimate accolade, and certainly from an academic point of view in the field of regional anesthesia. And but I was surprised, but hugely thrilled. I'd received other awards at other times, but this was overwhelmingly the best award that I've ever received.
I'd like you to ask or offer a word or two of advice for those young faculty and trainees out there who are doing regional anesthesia now, maybe who look at the scholarly accomplishments of people like you and feel like there's nothing left to do research on or study in this field. You have any advice for them as they kind of explore on their career?
No, I think what you have to do is you've got to be sort of mentored, and ideally set aside some time to do research on a full-time basis. It's very difficult for clinicians to do that. A lot of clinicians, for monetary reasons and lifestyle reasons and pressures of paying off loans and things, don't want to take extra time off. But I did that in medical school and took a year off in medical school. And I think it was probably the most formative time in terms of me learning the skills and the will to do research. I think you've really got to be motivated to do it, and you need a mentor, and you need to be trained. I think the training periods can be shortened now. The methodology and research courses often only take 3 months to do. And then it's, what I always did is I always focused on the challenges in the day-to-day working as a clinician. There are always things that you notice and things that you can try and improve. And once you get started, I think that you can get underway. And a lot of people doing research now are doing population studies, and the use of statistics, of course, has expanded dramatically and become a lot more sophisticated. So you have to get some appreciation of all of this. But I think the thing is to not get daunted, but to get trained and have a mentor, and then just pursue it and don't give up. And I think that you'll be surprised once you get into something, things start to open up and more things occur, and many projects lead to questions rather than answers, right. And you get yourself going. So, and I think that makes it for a more fulfilling career, and then you can be sort of part of the society more, and I think it's very good. the majority of people in the society are probably clinicians only and not researchers. And in our department of about 80 people, I think we have probably 6 or 7 people doing research, which is pretty good. And you probably have a similar ratio in Vanderbilt.
We've probably got more. We've managed to get more people doing both clinical and research stuff.
Well, that's
we probably have
wonderful.
6 or 7 doing dedicated research, but lots of people doing side research.
Yeah.
And we're lucky to have a department that supports that. And then have, like you said, seeking out mentors is often the hardest part. And
Yeah.
luckily the society, ASRA Pain Medicine, offers mentorship too, which has been a big part of it too, which has helped many people build their career off of that.
Sure. Yeah. The other thing that's very important is you need some sort of funding. And
Yeah.
I think that's always a big thing for a department to set aside some money to do that. It was very good. What we have at HSS is a 5% tithe for research from gross income, which provides an ever-changing list of what it is, but it does support research, and increasingly it's supporting salaries, support for those who choose to take time off to do work. So I think, you do need some sort of funding support for it.
Well, Dr. Sharrock, it's been such a pleasure talking with you. This is, I always love listening to the people who've come through these struggles and these challenges and successes in the past, because I think there's always lessons to learn from that for future success. And your work in this field and what we do today probably touch my practice every day, and I don't even think about it. And so I appreciate all of your hard work and everything that you've contributed to the field. And we really appreciate your time and your contributions to the society as well.
Well, I thank you very much for taking the time, and it's been a pleasure to be interviewed by you. And I think you did an extremely good job, and I thank you for the opportunity.
Thank you so much.
Okay, Raj, thank you very much.
Bye.